Good morning, doctors. Welcome to another podcast on CGHS clinics. A patient of dizziness gives a lot of dizziness to doctors in evaluation and treatment. To help us in understanding how to evaluate a patient of dizziness in wellness center, we have with us again Dr. Hema from Chennai to tell us more about how we should approach a patient of dizziness in wellness center.
Good evening, friends. I am here again to talk to you about another commonly seen symptom in our OP setup, which can be confusing in its presentation and frustrating in its treatment, that is, dizziness. Dizziness is an imprecise symptom generally used to convey a variety of sensations like giddiness, imbalance, faintness, or lightheadedness. These could clinically mean any of the following four: vertigo, which is the most common, disequilibrium or gait disturbance, next pre-syncope, and finally faintness or lightheadedness, which is the least common. When we are approached with a patient with dizziness, it is important for us to clinically diagnose and characterize the symptom. For this, history again plays a major role. The patient is asked to describe in his own words the exact sensation that he feels. If he feels a false sense of motion, a spinning sensation lasting for a few seconds, he is most likely having vertigo. If he feels off balance or wobbly while walking, it is disequilibrium. If the patient says he has a feeling of falling unconscious or blacking out momentarily, then it could be pre-syncope. Vague symptoms, possibly feeling disconnected with the environment, could be lightheadedness. Next, in the history, one should ask about the onset, duration of the symptoms and associated symptoms. Do the symptoms have an acute onset, or have they been there for a few weeks or months? Are the symptoms momentary in nature or episodic, or are they persistent? Are the symptoms associated with a change in posture, or are they there all the time? Are the symptoms associated with deafness or tinnitus? Do the symptoms occur while walking, or are they associated with palpitations? Sometimes dizziness can be a red flag symptom of a dangerous condition like pre-syncope of arrhythmia or stroke. Especially in older patients who present with acute symptoms, we should always evaluate for a possibility of stroke and look for signs supporting a brainstem or cerebellar hemorrhage or infarct like diplopia, weakness, or dysarthria. Once you rule out these dangerous conditions, history will further guide you into differentiating whether the dizziness is of vestibular or non-vestibular origin. Vestibular origin of dizziness is usually provoked or aggravated by movement and improved or relieved by rest, and this vertigo may be central or peripheral in origin. Again, history of weakness, dysarthria, diplopia, or head injury will guide you to its central origin of vertigo. If there is a history of tinnitus, deafness, or oral fullness, it could be a peripheral origin of vertigo. A non-vestibular origin is usually due to pre-syncope of orthostatic hypotension, where history of multiple drug usage, diabetes mellitus, coronary artery disease will guide you to its diagnosis. The other less common cause of non-vestibular type of dizziness being disequilibrium, where there is a history of Parkinson's disease or symptoms of numbness in the feet or abnormal position sense. In case of faintness, there will be a history of anxiety or depression. Physical examination involves a thorough neurological, otological, and cardiovascular examination, which will lead to a diagnosis of the cause of dizziness, especially when history is ambiguous. While examining the cardiovascular system, the blood pressure of the patient is recorded in both supine and standing postures, as well as heart rate and rhythm are recorded. While examining the neurological system, Look out for weakness of the lower limbs, signs of Parkinsonism, do a Romberg's test and a tandem walking test. When a patient has nystagmus, specific note should be made of the trajectory. Purely vertical or torsional nystagmus suggests a central lesion, whereas a mixed horizontal torsional nystagmus suggests peripheral vestibular nystagmus. Also, note the direction of the nystagmus, whether it is direction changing or direction fixed. Peripheral vestibular nystagmus produces a nystagmus which beats in the same direction regardless of the eye position. Nystagmus which changes direction with different eye positions, for example, beating to the right or on right gaze and then beating to the left on left gaze, may indicate a central neurological lesion. The nystagmus of peripheral vestibular disorders tend to be attenuated by visual fixation, and so nystagmus may not be detected in the conventional manner in these patients. The dynamic visual acuity is an additional method of determining whether there is bilateral peripheral vestibular disease. In healthy people, the dynamic binocular visual acuity is similar to the static visual acuity. If they can read the 6 line on the Snellen chart, then they will still be able to read the same line while their head is moving to and fro at approximately 2 cycles per second. In patients with bilateral peripheral vestibular impairment, the visual acuity often drops several lines from the static to dynamic condition, for example from 6 by 6 to 6 by 36 or 6 by 60. Examining the otological system, look out for vesicles near the external auditory meatus and also perform the Dix-Hallpike maneuver, which is diagnostic for benign paroxysmal positional vertigo, the commonest cause of vertigo. As in syncope, investigation plays a very small role in diagnosing the cause of dizziness, and the choice of investigation should be guided by history and examination findings. It does not replace a thorough clinical assessment. It is used mainly in a case of vertigo to distinguish peripheral from central vestibular disorders and to characterize the dysfunction. Audiometry is used when vestibular disorder is suspected. Electronystagmography or video nystagmography, caloric testing are used to quantify the vestibular dysfunction. Neuroimaging is used whenever a central vestibular cause is suspected, especially in case of unexplained unilateral hearing loss or vestibular hypoperfusion, where MRI with gadolinium is done to rule out schwannoma. Now let us have a quick look on the pathophysiology and diagnosis of some commonly seen causes of dizziness. Benign paroxysmal positional vertigo, the commonest cause of vertigo, is due to loose otolith in semicircular canals causing a false sense of motion. This is diagnosed by symptoms of episodic vertigo without hearing loss. A positive Dix-Hallpike maneuver is diagnostic of this condition. Meniere's disease also causes vertigo, where it is due to increased endolymphatic fluid in the inner ear, causing episodic vertigo with hearing loss. Migrainous vertigo causes vertigo due to uncertain causes. This leads to episodic vertigo with signs of migraine plus any of the following: photophobia, phonophobia or aura during at least 2 episodes of vertigo. Parkinson's disease causes disequilibrium type of dizziness, where the pathophysiology lies in dysfunction in the gait, causing imbalance and falls. Diagnostic Parkinson's sign of shuffling gait with reduced arm swing and possible hesitation. Peripheral neuropathy causes disequilibrium due to decreased tactile response when walking, which causes the patient to be unaware of where his feet touch the ground, leading to imbalance and falls. Eliciting decreased sensation in lower limbs, particularly the feet, diagnoses this condition. Dix-Hallpike maneuver. While the patient is in a seated position, the physician A turns the patient's head 45 degrees to one side, then B rapidly lays the patient into a supine position with the head hanging about 20 degrees over the end of the table, observing the patient's eyes for approximately 30 seconds. The maneuver is repeated in the opposite side. Nystagmus is diagnostic of vestibular debris in the ear facing down. This is a useful chart on approach to the patient with dizziness. When a patient presents to you with dizziness, first ask him about medication regimen, caffeine, nicotine and alcohol intake, history of head injury or whiplash injury. Then ask him to describe the exact sensation that he feels. If he feels a false sense of motion or spinning sensation, he could be having vertigo. If the vertigo is associated with a current migraine attack or has past history of migraine symptoms associated with vertigo, then it could be migrainous vertigo. If the vertigo is associated with hearing loss and is episodic in nature, it is Meniere's disease. Persistent vertigo with hearing loss is labyrinthitis. Episodic vertigo without hearing loss is benign paroxysmal positional vertigo, which can be further diagnosed with a positive Dix-Hallpike maneuver. Persistent vertigo without hearing loss could be vestibular neuritis. And now the specific treatment for BPPV-EPLEY maneuver, which can be done at our outpatient setting. The technique involves a series of movements. A. The maneuver begins with the patient sitting with the head rotated 45 degrees to the right. B. The physician lays the patient into a supine position with the head hanging over the end of the table. C. The head is then rotated 90 degrees to the left. D. And the head and body are rotated together an additional 90 degrees until the patient is 135 degrees from the initial supine position. E. The patient is brought to a sitting position while the head remains tilted. Finally, the head is brought forward and downward to an angle of 20 degrees. The physician should pause at each position until nystagmus resolves, and the whole series should be repeated until no nystagmus is present at any position. The maneuver can also begin with the patient in the supine position. A video demonstration of this maneuver is available at this site. Majority of patients with Meniere's syndrome respond very well to conservative medical management, which includes a low salt diet and possibly diuretics. Vestibular sedatives and antiemetics may be useful for prolonged acute attacks. Short-term corticosteroids may be useful in refractory cases with relatively preserved hearing. More aggressive therapies such as intratympanic gentamicin or surgery are reserved for refractory cases which are unresponsive to other measures and where there is significant hearing loss. Vestibular rehabilitation therapy may be useful in patients whose symptoms are stable. Vestibular neuritis is treated by bed rest and vestibular sedatives and antiemetics for the first 24 to 48 hours, after which they are tapered. Methylprednisolone is effective and started within 3 days, where depomedrol initially 100 mg orally daily is given and then tapered to 10 mg orally daily over 3 weeks. Methylprednisolone was found to be more effective in improving the peripheral vestibular function than valcyclovir in patients with vestibular neuritis. Vestibular sedatives should not be continued beyond the first several days, as they can impair the central compensation and recovery. Migrainous vertigo is treated in the acute phase as any other migrainous attack with aspirin, non-steroidal anti-inflammatory drugs, triptans and antiemetics. Migraine preventive treatment is used to prevent further attacks. Drug treatment of orthostatic hypotension includes fludrocortisone, a mineralocorticoid which is used to increase sodium and water retention. Here, monitoring the blood pressure, potassium level and symptoms of heart failure are important. Next is midodrine, an alpha-1 agonist metabolite which is used only in severely impaired patients. Pseudoephedrine 30 to 60 mg orally daily, paroxetine, desmopressin 5 to 40 microgram intranasally daily are other drugs used. Non-drug therapy includes replacement of fluids, rising slowly from lying or sitting positions, sleeping with the head of the bed elevated, increasing salt intake and regular exercise. Treatment of disequilibrium involves treatment of underlying disease condition like peripheral neuropathy or Parkinson's disease. Lightheadedness due to hyperventilation syndrome needs breathing control exercises, which involves rebreathing into a small paper bag, which causes reversal of hypocapnia related symptoms. Beta blockers may be used to treat associated symptoms like palpitations and sweating, and not for use in patients with asthma. Anti-anxiety agents, SSRI inhibitors, or short-term use of benzodiazepines can also be used to treat underlying anxiety. To summarize, for most patients with dizziness who come to us, a careful history taking and a thorough clinical examination can lead us to the cause of the dizziness, help us to reassure the patient, and also many times give a specific treatment. Thank you. Thank you, friends, and thank you, Dr. Dadke,